We wanted to talk about some of the work that's going on right now in emergencies and how the organization is working on the ground there. Joining me, back by popular demand, Dr. Elizabeth Hoff, our head of country office in Syria and one of our most popular people from last year, Dr. M.Aabdel, who is the acting director of Emergency Risk Management and Humanitarian Response, which is a very complicated way of saying she is overseeing all of our emergency work at this point in time, and Karim Tawab. He is a young leader from Egypt who is a medical student and is working on humanitarian action in a very important area of humanitarian action right now. Now, Michelle, let me start with you. Today, there are major emergencies going on. Now, at WHO, we divide emergencies by grades, 1, 2, or 3. 3 being the highest, the biggest response needed, and that pulls on all aspects of the organization. So it is considered a very major response if it's a level 3. How many of those grade 3 emergencies would you say that WHO is responding to today, and what are they?
Right now we have 6 grade 3 emergencies. We had 7 when the Philippines typhoon happened, but right now we have obviously the major response to the Ebola outbreak in West Africa. We have the response to the Nepal earthquake, which happened quite recently. And then we have 4 other grade 3 emergencies, which are long-term, large-scale conflict situations, and they are Syria, Iraq, Central African Republic, and the crisis in South Sudan.
Give me an overview here. How does WHO work in these emergencies? What is it that we're due?
Okay, look, let's, before we get to these emergencies, we take a step back. WHO actually works with all our countries before an emergency even starts. And we work with them to prepare them for any kind of event, whether it's a natural disaster such as an earthquake or a typhoon, or whether it's to deal with a conflict like in the Syrian Arab Republic. So our role is to really help the countries to be able to prepare themselves in case something happens. Because if you think about Nepal, who is the first responder?
That's right.
Not us. It's the community that is responding first. Who detects an outbreak first? Not us. It's the individual that notices something wrong and then goes and seeks help, and that person at a healthcare facility might get tweaked to an idea. So really our role is to prepare those countries to be able to get that response going first. Now, what do we do when a response actually happens? There are many things, but on the whole, in terms of a disease outbreak, we are trying to help to put in control measures to contain the outbreak, whatever they are. And for a different type of outbreak, there will be different things that we'll put into place. It might be water and sanitation, it might be burying bodies properly, as in with Ebola. For natural disasters and humanitarian emergencies that are caused by conflict, our role is really to make sure that we provide people with basic health care that they need, and to help prevent any further disease. So, for example, if you need to seek health care for injuries because of conflict or because of the earthquake, you need to be able to go to a hospital. If the hospital is damaged, we try and support bringing in different foreign medical teams to support the delivery of those services. If you need a cesarean, it doesn't matter whether it's just had an earthquake or there's conflict going on, you'll still need to deliver a baby. How do you access that service safely? How do children get vaccinated? So our role is to make sure all of this is still going on. The most important thing is to make sure that people's lives are saved, regardless of what is going on, but to do it fairly so that people who are in need are able to get those services fairly. One of our biggest roles actually in that case is the coordination. Many people come to help, as you know. In these situations. Not so many people come to help in conflict. They certainly come to help a lot when there's a natural disaster, but our role is the same. We coordinate the partners that come in. In Nepal right now we're coordinating over 100 partners, for example, and Elizabeth will talk about the coordination at the country level in Syria. We need to make sure that we don't duplicate efforts. So in one area you don't want everyone to be providing primary health care. You want surgery and maternal care and reproductive health, mental health. So that package, and that's where our role is very strong. Our final role really, what we, World Health Assembly, we're a technical agency. We want to make sure that the standards are correct. What are we doing? Is it of good quality or not? We're not going there to experiment. These are human beings, and they need to be given the quality of care that we provide to our own populations anywhere else.
Really useful way of explaining what we as an organization do, and I remember Even hearing about hospitals that did not collapse when an earthquake happened because we had worked with the government to help retrofit them before, because we knew that they lived on a fault line and we knew this was a high risk. So really pays off in the long run. Let me ask you one last question. Some of these emergencies, for example, Central African Republic, they fall off the radar screen when the media leave, and it's not such a hot issue and it's not constantly in the media spotlight. How challenging is it for you and your teams to get the resources they need in emergencies like that when the media is gone and the work has got to continue?
I would say extremely challenging, and we are less than 20% funded for this year, as for many of these chronic emergencies, because the attention goes away. And let me say that these countries have long-term effects on health of the population. So this is not just for a few weeks. Years and years and years of poor child health, poor maternal health means that, for example, in 7 out of the 10 countries where we have emergencies, there is the highest child mortality rate. In 6 out of the 10 countries where we're working that have emergencies has the highest maternal mortality rate. So these are not acute emergency countries with earthquakes. These are ones with chronic, long-term protracted emergencies. So if we let the attention die off these countries like Central African Republic, we're never going to reach the global goals that we want to improve the lives of people and attain these goals in terms of under 5 mortality and maternal mortality. So it's a huge challenge, and we keep working in them whilst the attention goes away. As I said, WHO is we're there before, during, after emergencies. And that is one thing that I think we should really highlight to the world.
Yep, absolutely. One emergency I would say that's hardly forgotten but is absolutely heartbreaking is the one you work in and day out. Elizabeth is our head of office in Syria, and you've been there for what, three and a half years now? Yes. Absolutely tireless at her work. Elizabeth, kind of put an on-the-ground perspective here for me on what Michelle's been talking about. What is your daily work there working to achieve?
Well, we are now in the 5th year of the crisis in Syria, and there has been no stop to the violence. We have approximately 25,000 injured per month. And
per month?
This is, yeah,
per month. Did you say per month?
Yes. And when we put this into perspective to the other crisis, then we have to really look at the seriousness of what we are talking about. We have more than 7 million internally displaced in Syria. And where do they go? They go to where they can find some safety. And many of them are on the go, not for the first time, that they move from the rural Aleppo into Aleppo town. But now that has also become unsafe, so they are trying to move to Hama or to Latakia. But this is the everyday life for more than 7 million. And on top of that, we have more than 4 million Syrians who have left the country over these 4 years. So this is the struggle they are faced with. And what you can see is that the population, they don't really ask for the reason for the conflict and political constraints. Where should we go? They are more like animals. They are seeking, where do I find safe water? Where do I find care? Where do I find protection and shelter? So this is where they are moving. They are not asking, about conflict lines. The only thing they are asking for in this kind of emergency is some kind of safety for themselves and for their children. And what I would like to see is that they can find health care and also education for their children where they will settle down for some time. And when we talk about who is actually responding to this emergency, I would like to follow up on what Michelle was just saying. As the UN, NGOs, communities, but really in Syria it is like another emergency, the Syrian people who are actually taking care of the people. Mm-hmm. Most of these internally displaced are actually hosted by the Syrian families. But unfortunately, after more than 4 years of conflict, their coping mechanisms are exhausted. So this is where we are seeing that almost all the families in Syria today are affected. They are struggling with anxiety, with grief, having problem of finding health care. More than 50% of the hospitals have been now damaged or are partly out of service. And 40% of the primary healthcare services are no longer functioning. So what we are hearing is that many patients in acute need of care, they are traveling 160 kilometers to find primary healthcare services in many of the areas. And what Michelle was referring to, also for example, women who are in labor, they are so afraid because how can they make sure that they can travel at night? Because you don't know when is the onset of the labor. So will it be safe for them to travel? They have to pass many checkpoints. So while before, all the deliveries were in institutions, hardly any maternal mortality in Syria. They had the best health indicators in the region throughout for maternal and child mortality. Unfortunately, this is no longer the case. We have a drop in the vaccination rate from 92% before the conflict started to around 50% today. And we have had outbreak of polio. And we are seeing measles, we have waterborne diseases. You know, in these shelters where the people reside, between 50 and 70 people are sharing one toilet. So then you can understand that there is really diseases on the rise. And we have difficulties with making sure that when we are delivering protective, preventive messages, you know, that how can they access water to wash their hands? Many of them have water 3 hours every 3 days. So you can see the constraints that many of the people are facing.
You know, I was going to ask what some of the health impacts were, and I think you have just summed it up beautifully. It's really hard to imagine that. I want to ask one last question for you. How, as an organization, do you and your team manage to get the supplies, the equipment, the materials that you're moved around in a place that is that difficult?
Access is the main challenge. But I would like to say that WHO has a very good credibility in the Middle East and also in Syria. And this has helped us enormously when I came in 3 years ago. To build on this credibility, the trust, and to keep up a very transparent and frank dialogue with the authorities, whether it is at the central level or at the local level, to negotiate access. But we have today more than 4 million people living in hard-to-reach and besieged areas. And this is what we are facing is really to make sure, and it is not enough. So I think that the UN in general had done a fantastic job with opening up for cross-border and also to strengthen cross-line deliveries so that we can cater for these needs. But for WHO it is also not only to think about sort of the people in the besieged areas, but also all the people who are actually staying in shelters and in need, because as I was saying, every family is affected, so we have to strengthen the services throughout the country to make sure that we have medicines that we can deliver. Also mental health services is very important. 50% of the population is suffering today from mental distress and psychosocial distress. So this is what we need to do. And we have actually a multi-pronged approach as WHO. We have identified very clearly our intervention areas. We are focusing on primary health care, including mental health, and we are also strengthening the referral services for secondary care. So we see that what we are doing is paying off. We have gotten good donor support. We need, of course, more to do more. But what I would like to say is that we can say that we are delivering. Last year we delivered more than 14 million medical treatments. So far this year we have delivered more than 8 million treatments. And we are receiving very positive feedback from the Syrian people because we are impartial in our work. Equity and fair delivery is really what matters. Every Syrian should have access to good health care to the extent possible.
I'm going to ask you a question that just came in on Twitter here, and that is what strategies are being discussed to improve that access to health care for the people who are displaced, which you were just talking about?
Yeah, I would just give an example. I was recently in Latakia governorate, which is one of the safer areas. They had received, before the attack on Idlib, more than 1 million internally displaced. They have an influx of an additional few 100,000, and this is a population of 1 million. So, of course, their services, which they normally had, is totally overstretched. So what we are trying to set up is also with mobile teams, health teams, to go to visit in the shelters, in the homes, to help out, to make sure that we have supported with mobile clinics, sort of ambulances, almost like buses, where we drive into the neighborhood so we can reach them. And this is for the internally displaced, and we are trying to do the same in hard-to-reach areas. But what we are trying to do is really to focus on the essential, that we cover vaccination, that we are covering antenatal, delivery and postpartum care, following up on children under 5, and making sure we reach the people where they are with the services.
Elizabeth, I'm going to ask you to come back a little bit later in the show. I have a segment talking about mental health care in emergencies. I'd like you to stick around if you don't mind, and join us for that discussion as well. Michelle, let me come back to you for just a moment. What would you say on a bigger picture are some of the biggest challenges that you and your team face working in emergencies?
Christy, right now we're dealing with emergencies on an unprecedented scale. So I mentioned the 6 grade 3 emergencies, but right now we're responding to over 30 emergencies in total as WHO. But the fact is that they are so large, they're affecting such large populations. They're complex because there's conflict, and they're of long duration, and the scale is enormous, not just in terms of geography as well. And so in terms of the challenges that we face, to be able to access, as Elizabeth was saying, remote areas, areas that are fraught with insecurity, our biggest challenge is to be able to get to the people. And we have to think of all these innovative mechanisms and approaches to reach them. But remember, we have to protect our own staff as well. So working in these difficult operational contexts is high risk. And this is one of the huge challenges of the organization, to make sure that our staff are safe, that our partners that we work with closely are safe, to be able to go and deliver the basic services to this population. And it's a highly difficult environment. We're not negotiators, but sometimes we have to negotiate with people. You know, we're health people, we're doctors, we're nurses, community workers. We have to negotiate with people to get access. And I think that's some of the biggest challenges operationally. We have to set up sub-offices in very difficult locations. We have at least 5 in Iraq. We have 3, soon to be 5 in Central African Republic. We're not just working from a remote basis. We're actually out there trying to be right amongst the population. But the final point I'd like to raise is, we have never seen such a level of attack on healthcare. It's unprecedented. It's as if international humanitarian law doesn't exist. There is no neutrality of the healthcare system. So healthcare facilities are bombed, healthcare workers are attacked, kidnapped, ambulances are sieged. This is not normal. We should have a space to be able to provide aid, because we are neutral and we want to be fair. And no one is obeying this, and I think this is one of our major challenges.
I think that's a perfect setup for Karim here. Karim from Alexandria in Egypt, and working on as a medical career, and you're particularly engaged in this. You've had some experience with this. Tell me about your experience.
Yes, so in Egypt, as a medical student, we have working in the International Federation for Medical Students Associations. In our general assemblies, we had, and in our regional meetings also, we set up in collaboration with the International Committee for Red Cross and Crescent and the Egyptian Red Crescent. We worked together on a project called Healthcare in Danger, where we educated the medical students and also parts of healthcare providers, pharmacists and nurses and others, on how safe access to conflict zones, first aid and safe exit, which were very important. What we did is that in collaboration with the ICRC and the Egyptian Red Crescent, we set up this big simulation in Egypt. It was in Cairo. There were actors, there were people, actors for pretending to be victims, families, so that the medical students can undergo the pressure that is put on them from the families of the victims and the casualties. And it was really successful. participants came out, they know now how to act in conflict zones. They can participate whenever there's a riot, whenever there's war, whenever there is any disaster or conflict that may arise in the country. And what's good is that it was done in Egypt, but there were many participants also from across the region. So we had participants from Morocco, we had participants from Tunisia, Lebanon, and other countries in the Gulf region.
You know, and it's really that type of work, I think, that's going to have to build the grassroots and the momentum.
Absolutely.
And the pressure for building that respect for the international humanitarian law, as you said. We're going to have to stop it there. I think we could probably talk for another hour or two with you three. But really, whenever you think you're having a rough day, think of the three people sitting at this table. My goodness, you have... Yes,
absolutely, yes.
You have quite a job to do, and I thank you all for doing it.
Thank you, Chris.
You stay close, but you can take a break for just a moment. Michelle and Karim, thank you so much for joining us.